So good morning and welcome. It's great to see you all. On behalf of the trustees and the staff of the Nuffield Trust, I'd like to welcome you to the 2025 annual summit. My name is Martin Marshall and I'm chair of the trustees. For the last few years, I've stood up here at the beginning of the summit and said, the NHS and social care is struggling like never before. And this time I really mean it. And of course, it's the context, isn't it? Because the challenges that we face in the NHS, for example, are very familiar and very enduring challenges. Balancing budgets, hospital waiting lists, access to general practice. We've been there before. But the context within which we're trying to address those challenges, the national economic context, the global political context, a context in which there's genuine discussions about where we use public resources, is a very challenging and a very difficult one. And that's why I think the work of the Nuffield Trust is so important to all of us. We bring our independence, our ability to say what needs to be said without any vested interests. We bring our commitment to high quality research, our commitment to rigorous analysis, to discussions. And our main challenge, our main purpose is to generate debate, to devise solutions and to build consensus around those solutions. So all the things that we are here to do as the Nuffield Trust seem to be particularly important at the moment. Now, our feedback from last year's summit was content brilliant, not enough downtime and not enough time for interaction. So we've done our utmost to correct that this year. You'll see only slightly longer coffee breaks, but lots of participative sessions in which we're looking to you for the answers to the challenges that we face. And if the answers to those challenges don't exist in this room, they don't exist anywhere. The programme, I think, is a really exciting programme, a really fun programme. We're going to be kicking off with Thea, our Chief Executive, talking about the psychology of change, the how rather than the what of change. We've then got a session on the 10-year plan, and we're delighted that Sally Warren is going to be leading that session. It's going to be a pre-mortem. I don't know how many of you have done pre-mortems before, but it's a really interesting approach in which we're going to ask you to project yourself to sometime in the future, the not too distant future, to imagine what it would be like if the 10-year plan had not achieved the ambitious attempts that it's got to reform the system, and for you to discuss what went wrong and how could it have been done better. So a really interesting session, I think. We've got sessions on the GP contract, on NHS continuing care. This evening, we've got a session on social media and its role in communications. That's the only session in which we encourage you to bring a glass of wine with you. And we've got some really quite challenging conversations about the moral challenges that we face, the moral conundrums that underpin so many of the difficult decisions that we have to make around reform. So we've got sessions on racism, sessions on end-of-life care, and for the first time, the BBC is going to be joining us tomorrow for a pre-record of The Moral Maze. So we're going to be talking about what is the ethical purpose of the NHS. So it's going to be a programme in which you are the audience. It's going to be broadcast sometime in April, and Michael Burke will be giving you some more details tomorrow. So be prepared for that. I'd like to thank our partners. We have 3 partners who we work with closely. They bring content, they bring sponsorship. We wouldn't be able to run this summit without their support. So thank you very much indeed. They're going to be running 3 workshops. These are invitation round tables. Newton are doing one on productivity, Optum are doing one on technology, and the BMJ group are doing one on freedom to speak up. So over the next couple of days, I think they're going to be really interesting sessions. So finally, a little bit of housekeeping. Most of the sessions are going to be live streamed, so there's going to be audiences outside this room as well as within this room. We encourage you to use social media, #Nuffield Summit. Our primary platform is Blue Sky rather than Twitter. No judgments being made there at all. There are roving microphones. If you'd like to contribute to any of the sessions, then please put up your hand and the microphone will come to you. Please stand up if you're able, give your name and organisation, and as succinct question or comment as you're able. Phones, dreadful things, please throw them away if you possibly can for the next 2 days, or at very least turn them off. And tomorrow there will be evaluation forms on your table, so please use those. And finally, there's no planned fire alarm, so if one goes off, it might be the real thing, so please follow the instructions provided by the staff. I hope you enjoy the next couple of days. I think it's going to be really fun, and I hope it's going to be very productive as well. And I'd like to hand over to Thea, our Chief Executive, for the first session, in which she's going to give a presentation on the psychology of change, and is going to be joined by Charlotte Pickles, who's Director of the Reform think tank, for a conversation. Thea, over to you.
Thank you. As ever, the tallest person in the room is then followed by probably one of the shortest people in the room, so have to just move all of this. So I'm going to talk about the psychology of change. I seem to have appointed myself the psychologist to the NHS since I became the chief exec of the Nuffields, for which I apologise, as it wasn't a role that was advertised and it wasn't a role that anybody else applied for, but here we are. So I want to talk about change and the challenges that change brings us. And why? Why now? Well, quite obviously, in a sense, why now? We've got a newish government, and we've got a 10-year plan on its way. We've got a reform or die mantra which is around. We've got another push on the 3 shifts. For this audience, I'm not going to say what the 3 shifts are in case I put you to sleep very early on in the day. We've got really significant pressure on local authorities and social care, our important partners. And we're told continuously there is no more money, there is no more overspending that's ever going to be allowed. We have a Darzi report that came out and told us all about the significant problems, which most of us in this room understood and knew, but laid it out in a really good way, a really clear way. I thought it was really important. And we've got public satisfaction that has never been so low. So whatever the situation, whatever the government, people in this room and all of us, we know we have to think about change. So what do I want to talk about? I want to talk about why large-scale change in the NHS in particular. So I'm not going to do that thing where you go NHS and social care, which I think is generally an insult to and social care. Where I think what I'm saying is relevant, I will hope to bring that out, and some of what I am saying is. But the NHS is particularly parlous when it comes to large-scale change. And I really want to focus on that. Why does planned change fail so often? Why our good intentions aren't enough? And goodness knows, if they were enough, we would have really achieved a huge amount over a period of time, but we haven't. And how, as a species, we're surprisingly resistant to learning about why large-scale change fails. It's actually not that surprising, but we're very resistant to its learning. One of the things that I'll talk about, and I talked about this a bit last year, so I'm potentially going to start becoming quite boring in a way, but that data is incredibly important. But data is only really important when it's alongside what I call ethnography. And it is ethnography, but it means going and being with people, seeing what people really do. And how we continue to think about change and to model change as though what we're dealing with is a complicated system and not a complex system. And the way it was described to me once, which I find useful as a way of understanding that for myself, is a complicated system is one in which I have a ball in my hand now, and I throw it to Naina in the audience. Physics will tell us, given my size, my height, my terrible ability to throw a ball, broadly where that ball will fall. That's complicated, but it's physics and maths. If I have a bird in my hand, and I say I'm going to now release this, and it's going to go to Naina, none of us really have a clue where it's going to go. There's a lot of complexity that we could understand about that bird, but it's much more complex. It's not just complicated. So I want to think about this in quite tangible ways. And the reason I want to think about it in tangible ways is that when you're somebody who stands on a stage and talks about the psychology of change and you talk about people, people can get a bit, she wants us to hold hands and sing Kumbaya. I really don't. But what I want to talk about is the levers for change that are there in the NHS: financial, workforce, structural, and a focus on prevention. I'm not really going to talk about prevention. Hard, complex, mathematical things, and say why they are also subject to the psychology of change. But to add to the challenge we've got at the moment, in society as a large, and the NHS, and also local authorities, we've created no-go areas. We've created areas where it's considered brave to talk about them. It's quite extraordinary, isn't it? We've considered something where if I stand on this stage and say, I'm going to talk about physician associates, guys, people go, are you? Are you really? That's for the NHS audience in particular. Are you really going to talk about that? Are you going to talk about racism? Are you going to talk about embedded medical power? Are you really? Even are you going to talk about the fact that the money doesn't look like it's enough? If you have no-go areas, you cannot have a good conversation. We, as leaders and opinion formers within NHS, social care and policy, can't be complicit in the idea that there are no-go areas. We have to boldly go. I did have a wonderful Star Trek slide, but it didn't work, which is really sad, but I want you to imagine it now. Because we can't even start conversations without change. But what we all want is a bit of magic. And that's what you see in policy. We all want it to be simple. We all want change to be a bit of magic. But often it isn't. So the NHS is its people, which is something we say all the time as we're very proud. The NHS is its people. But actually, the fact that it is its people is the reason why it's so glorious, so complicated, and why change is so hard. Because we like to think that we're unique and independent. We're often not. We like to be part of groups. We like to think as part of groups. We're often thinking as part of groups that brings us into some of the problems we have, bystander problems. Not speaking up because we're part of groups, because we're scared. Convergence of thinking. We're in a bubble of thought. We don't want to stand outside that thought, so it makes us feel anxious. We don't really want to rock the boat on a fear of conflict. All these things are really normal. They're really ordinary. They're because we are people. But they're also things we have to understand if we're going to understand change. And fundamentally, we found it really hard to look at things like embedded privilege, to look at embedded power, mostly because we all are powerful people. We all have huge embedded privilege, and we find it hard to think about it. And the NHS is its people, and so most responses to change are completely and utterly understandable, but we often don't look to understand it. I've said this before, and I'll probably go on saying it, whatever role I'm in. The people who do the work can change the work, but we completely continue to imagine that work as described is work as done. And it's just not. It's just not. And we often see it as strength to push against resistance when often we should be looking to understand it. And what if we really understood all of this? If we really thought about all of this? If we understood all our data and we also understood all of this psychology, all of this understanding about people? Steve Black quoted Douglas Adams in an article quite recently, and he said, the answer is really big. You just won't believe how vastly, hugely, mind-bogglingly big it is. And I like that, because it's true. So I want to talk a bit about financial incentives, and I want to talk about skill mix and taskification. I'll explain what it is. So history of financial incentives. There is a big, large-scale review of financial incentives, and I'm not going to go through all of it. My slides are available, etc. But what you'll see when you look at financial incentives, and it's not really been changed over time, but this is the biggest sort of analysis I could find, is that in most cases, the impact of financial incentives in the NHS is unclear. Occasionally, they're positive, and sometimes they have no effect or a negative effect. And the quote from it is, owing to this uncertainty and their significant costs, the use of provider financial incentives may be counterproductive to their goal of improving healthcare quality and efficiency. But we don't really like that. So we go, I think they'll work. I think this time they will work. The image that I'm constantly thinking about now is a bit like when somebody came to a very old house I lived in and their light had failed and they opened, the box with wiring in and sort of went, I can't mend that because the whole system needs to be rewired. I'm not saying we don't need to think about financial systems. We need to rewire it absolutely fundamentally. But what does the layering in of a financial incentive mean? The quality and outcomes framework, for those that don't know it, it's a way of working with primary care, with GPs in particular, in incentivizing particular practices. Again, what do we see from that? You can read this yourself. But basically, overall, looking at a whole range of studies, we see that the quality outcomes framework does lead to some improvements for some people at some points. And some of them work quite well. But at the very, very least, you've got to say it is complex and it is variable. And when you start looking at financial incentives, which I have now, you start realizing that the whole area of behavioral science, of behavioral economics, is really never used and never thought about in the really complex way that it could be, and I believe should be, when we're thinking about something so important. Mental health investment standard is one that we've looked at most recently within the Nuffield Trust. And broadly, what the mental health investment standard showed, which is good, is that money did go into mental health services. That's great. And that mental health services did more. We're not quite sure what they did or what the outcomes is, but they did more. But what we also show is that that money went into bank staff or agency staff. So you got an outcome, but did you get the right long-term embedded outcome? How were you doing it? Basically, the money came before the staffing was there. Even something like this, which on one level I'm not saying was not a good thing to do, has a really complex outcome. My chair, Martin Marshall, with a colleague Harrison, said, incentives do not produce rational or predictable behaviors. Who knew? Who thought? I mean, it turns out that actually we don't live or work according to economic models. We live and work and exist according to complex psychological variables. And what's really important is how does the external motivation of a financial incentive sit with your internal moral compass? What is it? You can't buy the right behaviors. You can actually crowd out the right behaviors, which is an economics term, by the wrong financial incentive. And most importantly, we actually don't really know how financial incentives interact with professional identity or with feelings of control, but we often have an experience of what it can do. This is just my favorite picture at the moment, so I had to use it. I'll just let you look at it. I'm not talking about prevention, but I think this tells you everything about why prevention is really, really hard and people are really, really complicated. Love the picture. I will always use it. So skill mix. We brought out a report on skill mix this year, and I think it's something that is important thinking about the interaction with us in social care as well, because we're increasingly talking about somehow taskifying, giving tasks to social care colleagues, to home care colleagues, etc. So I think this is around NHS. It's basically about the balance and the change in professions and who does what and how they do it and when. It's always been there since the NHS was created. It's become a bit of a toxic debate and a bit of a no-go area in the NHS, but it's worth looking at. Why do we do it? We do it for a whole range of reasons. We tend to do it to create new roles. We do it to increase the depths of existing roles, to move tasks from one professional to another group, to expand the breadth of a job, can be seen as substitution, where it starts to get very emotional. And often it's seen as being driven by cost and scarcity of roles. And often it is driven by cost and scarcity of roles. And of course, if you're in that space, you're then in a space where people have quite a lot of feelings. The emotional challenge around role replacement and professionalism is all about a sense of worth and a sense of purpose. It isn't just tasks on a sheet or bits of a puzzle. It can feel very difficult. When I started my career, I was a clinical psychologist, and I started at a time when counselling was just being introduced into the NHS. So I just finished my training. I'd done years and years to train as a clinical psychologist. And suddenly there was a view that counsellors, some of who had done 2 years training, could do some of my work. Clearly that was outrageous and probably not true. Turned out not to be outrageous and turned out to be true. But it helps me understand why people feel strongly and how you have to introduce and think about these things. Because if you introduce it without proper consultation, no capacity for mentoring, no onboarding, no real understanding, the unintended consequences and indeed problems with public understanding can be intense. And I'm sure you can all think of examples of where that happens. And we do it a lot in England, remarkably, and I would suggest those of you who want to know more, look at the really good report from the Nuffield Trust. We do a lot of it in England. We do more of it than we do in any other country in Europe. That I thought was quite remarkable when I read our own report. We do a lot of it, and yet we don't really evaluate what that means, what the impact really is. We're thinking about all sorts of things at the moment around what we're going to do with social care, and we're constantly taskifying. Taskification is an idea that came from the McDonaldization, I find this a really difficult word to say, the McDonaldization of the NHS. And George Ritzer, who's a sociologist, who talks about McDonaldization of society, where we can think about efficiency, predictability, and control, which you can see if we're all running a McDonald's, those things are really, really important. But we've brought some of that thinking unconsciously and unconsciously into the NHS and increasingly into the way we think about our partnership with social care. But that can lead to reduced worker autonomy. It can lead to reduced job satisfaction. That's quite complicated. Taskification can be useful to break a task into its constituent parts, but it can be challenging. I like the quote, McDonald's system offers comfort, but there's very little research. There is some on what it does to job satisfaction, what it does to feelings of autonomy, what it does to feelings of worth. And I think that's remarkable. We do it a lot in the NHS. We're doing it increasingly with our partners, both social care and voluntary sector. But we don't really know how that feels or what it means. And what we have to understand is that this is not simple, and that if you get it wrong, it can become a lightning rod for everybody's concerns and grievances. It can become the thing you talk about. And that's why we have spent a lot of time talking about physician associates within the NHS. I'm not talking about the rights and wrongs of that particular role and how it's worked and how it's not worked. But what I see is it became a place where you could talk about how you felt, because there weren't other places to understand that and unpack a lot of this. If you don't have shared vision, shared cooperation in the way in which this works, something that looks like a really clear and simple thing to do becomes something that isn't. Finally, I want to talk a little bit about some of the work from the Nuffield on the NHS staff survey. Colleagues have looked at the work of the data from the NHS staff survey from 2014 to now, and looked at it in terms of cohorts, in terms of age cohorts over time. Really, really interesting analysis using really different ways of looking at that data. Remarkably, other people haven't done that. I thought it must have been done, hadn't been done. What do I want to point out? I wanted us to think about, as my final sort of section, the younger group who are coming through, some of whom are in this room. That is the top line, 21 to 30, reporting a far higher rate of illness due to stress. 51 to 65 are doing okay. 66 plus, loving their life. Younger staff, less satisfied with pay. Again, at the top, 21 to 30, not happy. 66, 51 to 65, pretty okay. You don't even need me to explain to you what you're seeing there or what some of the underlying conditions in society are, cost of living, the world. But why is it so important? So I've talked about financial incentives. I've talked about workforce. I've touched on prevention. If the NHS are its staff, and it is, if social care are its staff, but I don't have this analysis, we have to understand what our youngest age group are experiencing and feeling within the service. And they tell us that they are working long hours. Some of our research shows that they are the ones who are going to be working more long hours, paid long hours, than other age groups. They're experiencing more stress. They're more dissatisfied. They are less engaged. They're more scared. They are least satisfied with their pay. And clearly, there's the context of the world at large. And they're less likely to think they have a good work-life balance than other people. And you can get into all sorts of conversations about the whys and wherefores of that. But you've also got to put alongside other things we know. We've got a dramatic fall in people going into nursing. We've got fewer doctors who are entering specialist training. And we've got more GPs working part-time. I think some of those things will come up later during the conference. So we have to understand this group. We have to understand this group and their experience of the service, their experience of the world. And we've got to put that alongside everything else we understand about what it means to be human within this system. But we find it hard to talk about. People don't stand up and talk about this a lot. We find it even hard to think about the different groupthink that goes on. The groupthink amongst groups of chief execs, the groupthink amongst consultants, the groupthink amongst nurses. We find it hard to look at problems. There's lots and lots of literature on willful blindness. We just find it hard. We find it hard to talk about power and embedded power. It's awkward, it's difficult. Goes back again to this concept of no-go areas. And we find it hard to talk about all these things because they're difficult and they take time and they're long. And all of this interacts with the world's moving really quickly. There's political expediency. There's a need for now. And so I would often get asked, but, it's all lovely, Thea. But, we got to move it along here. I haven't got time for all of this thinking and worrying about people. I think you don't ever have time not to think about people. I don't think you ever have time not to be obsessed with the psychology of how people think, how people feel. Thaler, who is one of the gods of behavioral economics, so thinking about this all the time, said people are human, look around, observe. It's people who do the work and will change the work. I love this Mark Twain quote, "It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so." And we are really good when we're thinking about change, about knowing things for sure, that will work. We'll taskify. We'll put in a financial incentive. Nuffield loves a bit of evidence. I think we should all love a bit of evidence. I strongly believe that you do have time and that we do have time to take real care about how we do change, about understanding people and why change is hard. I think if you don't have that time, if you don't put that time in, even when the situation is urgent, you lose it. Peter Hyman, maybe a name that's known for some people but not all, was an advisor to Blair during the Blair years. When he left government, he said, he realised a lot of the things that he got wrong. One of the things he said, I realised real delivery is about the grind, not just the grand. It's about the combination of often small things that build over time through individual relationships, genuine expertise, and hard work. I think that some of what I'm talking about is always about relationships. It's always about the fact that it's the small things again, 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 and again. And I genuinely believe that we don't have time not to be obsessed with this. And that is me. Thank you.
Good morning, everyone. Is my microphone on? Can you hear okay? Yep, brilliant. Lots of nods, lots of smiles. That's a good indication to start the day. What a fantastic opening session, Thea. Thank you so much. An incredible amount in there, I think, for us to think about. So I'm Charlotte Pickles. I'm Director of Reform Think Tank, with the emphasis on think tank. I'll just mention that right now.
I'm just interrupting Charlotte to go help.
No, that's good. We'll definitely need water.
Thank you, Naomi.
There we go. So there's just a tremendous amount in there, and I think some really, really helpful challenges, actually, for us to start this two-day conference, which I'm sure will be fascinating, as it was in previous years. And I want to go through each of the kind of call them pillars, buckets, whatever we want to call that you talked about there. So the financial incentives, the structures, and the workforce, which are the things. We could add technology in there as well. They're the things that we always come back to when we talk about NHS reform and how we can create a more sustainable, more productive, more effective system. But I want to just start with a question around, I guess, where we are right now, and the context we're operating in. We've got the session on the 10-year plan coming up, and how far in all three of those buckets there is a distinction between the short term and the long term. And what I mean by that is, so if we think about where we are now, and particularly, right this week with the latest announcements on defence, we know that the financial settlements are going to be incredibly tough. There is no more money. I'm sure there are many people still hoping that more money will be able to be put into the NHS, but I think that looks dramatically unlikely. We also obviously have, as I say, the 10-year plan coming out, a 10-year plan off the back of the last 10-year plan, which was in 2019. So again, we're having those same conversations. Maybe we'll come to different answers. But it does feel like, if we think about the financial incentives you talked about, which on the whole are kind of short-term incentives, like can we do something about the tomorrow or maybe next 12 months? If we think about some of the workforce decisions, which again feel a bit like, there's a load of vacancies, there's a problem here, we know we're not doing enough here, so let's add some sticking plasters, let's create some other stuff in the short term. And in terms of the structures, I think there is an argument to say, we all said, we really need integration, so let's just, create these ICS things and they'll just do integration. But I'd argue none of those things have fundamentally thought about how the NHS functions or doesn't function. And I just wonder if you had reflections on that challenge between the short term and the long term when we have such a kind of burning platform at the moment.
Yeah, I mean, it's never easy. And in a sense, the simple answer is always try and make sure that the short-term things you do don't disrupt where you're going on your long-term journey. That's what we all say. As somebody who did run a trust, I would say it's incredibly difficult to hold to that. And it's incredibly difficult to make sure that all your short-term decisions do enable where you're going long-term. But I think there is the need for holding your nerve around some of it. So like with financial incentives, I strongly feel we need to rewire some quite significant parts of the way in which money flows and money works, which can include financial incentives as a part of it. But not let's just slap this on the top of it. It is really difficult when, it's the classic sort of metaphor. When the house is burning, you just want to throw buckets of water on it, and that's completely understandable rather than look at the source of the fire. But if you're not really clear in your thinking, okay, we are throwing a bucket of water on this fire, but we are still going to look at the source of this fire. We are going to have these fundamental conversations. We're going to understand this. Well, you just keep throwing buckets of water on a fire.
And so I'm struck by, I think we have a pretty good consensus of where we want to get to in the NHS, and I will add and social care on that, because I think, we are clear we really do want to see much better integration. If I think back to Patricia Hewitt's white paper all that time ago, which actually talked about the shift from hospital, from acute into community primary care. And so that holding the long term, if we then look at our behaviours over the last few years, they've in no way matched that long-term vision. So actually, even pre-pandemic, there was an increasing proportion of the money in the NHS going to hospitals, an increasing proportion, despite the fact that our stated ambition in the NHS, by the NHS, was that we would see that shift. We have seen an increasing number of doctors and nurses, but doctors in particular, in hospitals, despite the fact that we've said we want to see more, and GPs not changed much, health visitors, community nurses, district nurses, all gone down. So if we actually look at the stated aim of what the NHS says it wants to do, what politicians say it wants the NHS to do, and our actions, they're completely opposite to what we've tried to do. So how do we create that space, and what is the role of those conversations in no-go areas, as you put it, for us to try and work out a way of, as you brilliantly put it, holding that long term and making sure that the short-term actions we're taking are actually building towards that long term rather than making it ever further away.
Yeah, I mean, you've got to align everything you do. If you've got to align every single action. You've got to align every single piece of policy that you do. And you've got to, I would always argue, you've got to understand some of the things that are underlying that. If it's seen as prestigious to work in a hospital, but you are lesser to work in the community. I ran community services for many years. It was still something where nurses would say, I've come out of being trained, but I've been told I should go to a hospital first. Well, it doesn't take a genius to work. Well, it's considered. I was often said, you run Cinderella services. You run the Cinderella services. There are other people in this audience who are running Cinderella services. Language matters. People think that some of it is about, the big financial wiring you've got to do. And you do have to do big financial rewiring. You've got to do really significant things that demonstrate that you care that the core of district nursing has been decimated or health visiting. You've got to show that. But you've also got to show there's a parity of esteem between a GP and a consultant in a hospital. You've got to show that the way you train your staff demonstrates that. You've got to not assume that somebody like me was spending their time running Cinderella services. There's so much about language and behaviour. If NHS England visits, it used to be, you went to the hospital. We know that politicians go to hospitals. To be fair, Wes Streeting's first outing was to a GP surgery. And I know that was conscious. That was good. That was positive. Everything matters.
And I think that's absolutely right. I guess there's Wes Streeting's first action brilliantly was to go to a GP surgery.
Yeah, not everything else then aligned.
It was then to put billions and billions and billions of pounds into hospitals.
Yeah, I was trying to be positive.
No, I agree. We will. We'll pull on the positive threads that we find. But I do think the question about the money and where the money goes, I think it's very difficult to have those conversations about parity of esteem if actually the financial value you're placing on other parts of the system is so woefully lower than this other part. And that's both in terms of salaries and how much we're willing to pay those people in quotes high status roles, but it's also simply where the bulk of the cash from the NHS is going. So if you're sitting, it's great to see that we've had some increase in the GP contract, but it's nothing compared to what we've just seen in terms of the acute cash injection. And so if you're sitting in primary care right now, and even worse if you're sitting in social care where we're told we're not even going to get you an answer for several years, and you're sitting in community care, which is just basically never talked about, how are you supposed to feel a greater value yes, some visits, some warm words is nice, but when all of the money is going somewhere else.
It won't ever be enough. That's the thing about everything having to align. And I think there is the possibility of, because I believe that relationships are what make things work and make things fail as well, even where other factors aren't working. But you do need to be given a bit of a help by the other factors. So, in a good system, with good relationships with people, you can have honest, where you've understood your data, you've got one version of the truth, blah, 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 blah. You can have a conversation which is actually, would be much better if the whole diabetes service was run by community, or whatever it is. You can move stuff, you can work with the money you've got. But you've got to have alignment. So you've got things at the moment that say, if you're going to have charts and that show who's the most, who's doing best as an acute trust chief exec, and you're going to be naming and shaming, which seems to be where we're going, how are you going to how is you supporting those people to work in real psychological partnership with other people within the system, whether they're within the NHS family, out with the NHS family, when you're setting up a competition elsewhere? Everything has to align. At the moment, they don't. And if you don't have the situation which is allowing people to, if they have the ability to, not everybody wants to work in that way. There are some people who love to work in competition. I mean, I know that.
Yeah.
But if you are going to enable people to say, this is the only money we've got on the table. If you and I are in competition with each other, or one of us is a lot poorer than the other, we can't manage that money well. We just can't do it. But if we are enabled by where we are, maybe we can bring to bear the best of ourselves and make it work.
And so let's talk about the financial incentives thing then specifically on that, because I think that that idea of competition is actually really important here. And we tend to talk about competition in the NHS in terms of kind of patient choice and kind of driving up standards, etc. But let's talk about competition between different parts of the NHS. So at the moment, it would be great if our ICSs, our ICBs were created in such a way where there was some form of parity between the different parts of the health system, including social care, including community care, including local government, therefore. And yet what we actually have is a model which has embedded the power structures that you talked about in terms of the dominance of the acute sector, the NHS trust, the hospital trusts in that model. So how do you come together in a meaningful way if actually within the ICS structure, which is supposed to encourage integration, the power still resides and power very much directly linked to the money is still largely sitting in the hospital sector? And I guess that links then both to the kind of the funding model, and I remember when the integration white paper came out, gosh, what was it, a couple of years ago now? I'm terrible with thinking in time frames, but previous government. And it was, forgive me for people, there's probably people in the room who've worked on it, I apologise profusely, but it was a terrible white paper. It was so vague, it was so high level, it sort of said, well, people might think about pooling budgets, but, we're not going to require people to do that. But actually, if you're sitting there and your funding model is different for every part of the health system, and most of the health creation elements sit in other public services, largely with local government, how are you going to create within that? And that's not financial incentives in the sense of let's put a sticking plaster and incentivise, less smoking, for example. Yeah. Great thing to do. But it's not, as you pointed out, fundamentally rewiring. So how in a model which has still got the power imbalances, it's still got the financial imbalances, how are we supposed to move, and I will state one of the shifts, but from hospital to community, if we're not willing to grapple with those really big things?
No, you're not. I mean, you're absolutely not. And the only, one of the tools you have left within a system that isn't giving you the right model, the right incentives, the right structures to do this is actually behaviour and people and conversation and the ability to go to conversations that are considered no-go. How do you have the conversation with your acute colleagues about their power, about the power imbalance between them and even a local authority? You have left, in a sense, one of the strong things you have left is your humanity, is your ability as a group of people to try and work fairly decently with, and I know that I said to people, God, you just want us to hold hands and sing Kumbaya. I really, really don't. I think there is nothing harder than working at good relationships and having a conversation about power and having conversations about inequality and challenging people and having a good row and getting to the end of it and creating a conversation. Because we don't have money. We don't have some of the systems. We do have a wiring box that you open and go, oh, I don't think I'm going to look at that again. And so I believe that we have tremendous power left in understanding what you can do through good relationships, what you can do through bold conversations, how you can be thoughtful within the constraints you've got. But it takes a very different form of behavior and understanding and honesty. And it is so easy to put that in a box and go, fluffy nonsense, let's go back, financial incentives, taskification, blah, blah, blah.
And we've got great examples in some ICSs of exactly that happening.
Yeah, absolutely.
And actually, in several of those examples, they're not run by hospital trust or kind of acute sector clinicians or professionals. I guess to push slightly more on the box, that house that, kind of the electrician opens the box and goes, let's just close that back up, right? Let's, we'll put some plasters on, let's put some green wiring just to earth that thing, or whatever it is. You can tell I'm not an electrician. But at some point, we're going to have to open the box and go, we have to deal with this, right?
Yeah.
And those relationships, to make that work, and that really bold, as you put it, reform that's going to have to happen at some point, that will take immense partnership working, relationship building, visionary people who have compassion and an ability to bring people on that journey with them. But right now, we're not having that conversation, and we don't have enough of those people. And so if you look across the system, in many places, that's not happening. And so do we need to see, and let's put it in the most bluntest fashion, do we need to see the 10-year plan to commit to opening that box and saying, okay, deep breath, we're going to do this?
Yeah, and as far as, there is a finance and contracting technical group. I think there are people who are on that finance and contracting technical group here, and we may hear more when we do the 10-year plan. I think they have opened the box. I don't know what will come out, but maybe part of the conversation that will come out will be something that's a much more fundamental rewiring, like we saw. I have partial understanding of what's gone on in Denmark, but my partial understanding leads me to believe that some of that was because of a significant rewiring of inside the financial flows box.
Yep.
And so I want to be clear, when I'm saying financial incentives don't have the sort of the cycle, don't work often for a variety of reasons, I am not saying for one moment we shouldn't look at it, but we should look at it with real thought and care as well, and also understand that even that big rewiring, they did a huge rewiring in Denmark, it comes with psychological impact.
Yeah, brilliant, thank you. I'm going to ask one more question, and then we're going to go to the audience for questions. Selfishly, sorry, one more, I promise, and then think about the questions that you have, Thea. I want to touch on the workforce, and I'm sure there'll be lots of people in the room who also want to pick up on the points you made. And I guess this question about the different power dynamics, and we've touched on that quite a bit in this conversation, because I think it links to everything else that you talked about, and the fact that there clearly is quite a rigid hierarchy and rigid status. I'm sure we're all very familiar about some of the workforce staff survey insights, which are pretty damning around the culture for actually lots of different groups within the NHS. It's not a pleasant place to work for many people. But the question I'd like to ask is, how do we, we have in England a particularly specialised workforce, compared to other countries, at a time when frailty, multi-morbidity, the challenges, the trends we're looking at are actually going to require a much more generalised workforce. And I wonder whether there's an opportunity in terms of recognising the demand shifts and the need of a future model where the skills mix looks different, and also the fact that we have generalisation normally seen as a lower status than high specialised roles. Is there an opportunity there to use what patients actually are going to need and that kind of outcomes-focused narrative for reform to start changing some of those power dynamics?
I think that's certainly what Chris Whitty, our CMO, would want to see, has talked about very eloquently on platforms, including our own, around, and is leading processes to get there, to try and get there. But underneath that, as you reflect from what there is a journey to go on to, right from the start, you start your training, whether that's as a doctor, as a nurse, as an OT, as a physio, to start the training within a different mindset around how you work, who you're working with. And actually, it would take us into a different conversation. Also, risk.
Yeah.
We have a very risk-averse system currently within certainly the NHS. So even if you are a doctor or a nurse who may think, well, I can help you with X, we have set up for many people such a culture of anxiety and fear of, I should just work within here. So if I help Charlotte with this, is that right? Is that wrong? Is it holistic? Is it, I don't really know. There's so much to unpick. We've gone wrong on so many turns. And virtually everybody who started out on that path was a good person and still is. And so we've got such a lot to do to unpick some of these layers. And just one thing I would say before we go to the audience, I think we've got to be really careful about narratives around hospitals and communities as well, where hospitals are sort of giving to communities and hospitals start becoming bad and community good. Hospitals can be amazing, great and extraordinary, and communities can be absolutely dreadful. And we're starting to develop a bit of a simplistic narrative, which I don't think is helpful either. Right.
Great, thank you. We're going to go to audience questions. Already lots of people with hands shooting up. I'm going to take 3 at a time so that hopefully we can get through lots of people. So I think the guy there in the blue shirt's hand was up first, and then one in the middle and one at the front.
Okay. Good morning. That was a fascinating session. Thank you so much. I'm Liam. I'm a newly qualified GP. Thea, I'm fascinated by a relationship between 2 of the things you mentioned earlier. So 1, satisfaction with how things are currently, and 2, appetite for change. So when I speak to my newly career GP peers coming through, I hear a lot of things really aren't working quite well right now. We really need to think quite differently. We really need to be quite bold about this. And when I ask my later career colleagues the same question, as a sweeping generalisation, I hear, well, things aren't great, but take it easy, hold your horses, let's slow down a touch. Do you think there's a relationship between sort of how satisfied people are right now and how keen they are to see something different and bold? Thank you.
Thank you very much. And then just the gentleman in the middle here.
Yes, hello. Is this working? Yeah. So John Dean, I'm Clinical Vice President at Royal College of Physicians, physician in East Lancashire, and someone who's been working on change in hospital community shift for 30 years and not been very successful. My question is about trust, which I haven't heard. So we know that in large-scale change, we need goals, we need relationships, and we need to remove barriers. And I think what we see is lack of trust and safeguards put in because people are scared about releasing power. So how do we build that trust, have appropriate safeguards that then mean we can remove many of the barriers that are actually stopping the professional incentives actually to make these changes which we're all aligned to?
Yeah.
And some of those are financial, some of them are structural, some of them are cultural.
Yeah, sure. Do you want to take those two
Just
first?
because they're quite. So, I mean, I agree with you totally. Trust is. Relationships go at the speed of trust, don't they? And trust doesn't happen overnight. Unfortunately, you can be really skilled individual, but actually, how long it takes to trust. Tiny anecdote. When I was leaving my last job and had the usual sort of leaving party, there was a group of paediatricians in the leaving party, and I had a chat to them, and I said, are you going to trust the new chief exec earlier than you trusted me? Because I think it was about 5 or 6 years. I was there a long time. And they laughed and said, no. No, I don't think so. I said, it would be really helpful if you could move forward from the basis of the sort of trust that we've got and maybe fast track trusting the next chief exec. And we were laughing, and they were going, nah, I don't think so. And it was a fun sort of interaction, but it is true. It takes you time. And often, doctors in particular, and nurses, but doctors and GPs and local counsellors are people who are in their communities, in their institutions for a long period of time, and they will say to people like me, I mean, I was in my trust for nearly a decade, so was it, you come and you go. You come and you go. And so you takes time to create trust, and there are linchpins like GPs, like local counsellors, and building that's incredibly important. I couldn't agree with you more. The gentleman here, it's interesting. I think you harness the people who want change, really, don't you? I know people who are in their 50s, 60s, and 70s who are so extraordinarily animated by the concept of change. They are there, and I know people in their 20s who think that if you moved a pencil, the world's going to come to a shuddering halt. So I think in any organisation, whether it's a GP practice or an organisation, it's harnessing the people who are excited by change, who are willing to make a leap around trust to do exciting and innovative things. And they will do that even in the most constrained environment, given the opportunity. Definitely.
Can I ask you a quick follow-up, and then we're going to come to the gentleman, because I think it also links to those two things. So you talked about the kind of risk and the fear that creates, and I think that links to the taskification point, which is actually, okay, well, if we just do these individual tasks, we minimise risk. But I sort of reflect that then also contradicts what we all say as well, which is we'd like people to be working to the top of their licence, because actually that helps to increase satisfaction, and then maybe we'd be less scared about letting go of some other stuff if we were feeling like we were doing the really high value add things. And I wonder whether one, therefore, of the ways of trying to answer this is actually just to devolve much more power down to those who are delivering the services on the ground and who know their local populations, who know how things work and can build those really meaningful, trusting relationships in a place-based way.
Definitely. I mean, again, it would be a whole different conversation. A lot of clinicians don't like the phrase working to the top of their licence, because actually what they want is a variety of work. I mean, you can be quite burnt out if what you're doing is always at the top. Actually, you want a range. You want. But I think the core of what you're saying is absolutely right. Is what people want is support and being knowing somebody's got your back. Yeah. To do a whole range of things and to do a whole range
and having
of things
that freedom to.
Yeah, having freedom. And taskification is really interesting. I used to be much more. It's not all wrong, as I said, with my personal experience. Yeah. But it's complicated, and we do it as though it's transactional, and it's not, it's relational.
Yeah. Thank you.
Sam Everington, GP in Tower Hamlets, where we've had PCNs, advice and guidance, social prescribing, contracts for 10 years. It's a local contract with 2% of the local NHS budget going into primary and community care. I wanted to tease out two things with you, Thea. One was the parity of esteem, and particularly between acute and primary care, while wanting to avoid exactly what you describe, kind of the battle. But having done a lot of publications on race discrimination in the NHS, what I see is almost exactly paralleled in the parity of esteem. So I'm a professor. There's only 5.6% of professors of primary care. It should be 40% statistically. The training of doctors in general practice, very small fraction of their training. And I remember 7 years ago when I went for the job that Steve Powis got, an hour of conversation with the chair of NHS England at the time, which was all, well, if we put a GP in the post, we'd have to put a lot of support around it. So there's a lot of this parity of esteem. So the question is, how do we deal with that in a systematic way, like we have with race discrimination? And then the other thing is something around autonomy. So where I see greatest innovation in East London is where you give people the greatest autonomy for change. And the example I get from clinicians repeatedly is the ghastly mandatory and statutory training, which is going back to Noddyland every year to learn. And this is not how we learn. We learn in Tower Hamlets as teams. We learn about things that we don't know about, not what we do know about. And therein lies the bigger conversation about the balance between regulation and quality improvement. We put 600,000 into primary care a year, quality improvement. So where's the balance of that? And then very quickly, intergenerational discrimination, which you've highlighted, I think is a big problem in the NHS. And also, not just GPs and doctors in primary care, but what about the nurses? We have a practice nurse who's a full profit-sharing partner. That's a rarity.
Yeah, absolutely.
Thank you. Oh, that was 3 questions in one, so we'll take that one, and then we'll come out to other questions.
Do you want to take it? Okay. I mean, yes. I think what you've outlined is the complexity of parity of esteem, and it's got, you know, the roots are so deep. The roots are so deep around the lack of parity of esteem, and the lack of parity of esteem between people in the NHS and social care. I would say NHS colleagues are starting to speak social care, but they don't really. The lack of parity of esteem between voluntary sector and NHS. All of this, which you've got to work at if you're going to come to team, but between primary care and hospital, absolutely. At least you've got to talk about it at least, and often we don't talk about it.
And did you want to just pick up briefly, because you talked about it in the presentation, but this intergenerational difference in views and the you know, perhaps some of those tensions that might be creating, and maybe with an observation that I think a lot of the stuff that you've highlighted for the youngest age group in that would apply across the labour market, actually. And
Completely.
it's you know, I think we like to think that the NHS is special sometimes, but actually I think a lot of those trends are across the board.
Yeah, and we know that youngest age group, you know, they really value flexibility in work. They really value work-life balance in a way that older age groups will go, well, in my day, you know, we worked until midnight and we didn't get paid and we felt fine about it. It's like, well, we were mugs, you know, so why we want them to be mugs too? Yeah, I think, you know, whatever those of us in the older age group feel, we've got to understand a younger age group and know how we're creating job satisfaction for them. Otherwise, things are going to fragment across, as you say, a whole range of sectors, not just the NHS and social care.
Thank you. There was a lady just at the side there, and then there's another lady at the back, if we can go to, and then there was a gentleman who put his hand up very quickly, and I now can't remember. Maybe it was in the middle. Yeah, thank you.
Rupa Joshi, I'm also a GP and I'm also Deputy Medical Director for Primary Care for the South West region. I think something that you talked about really, you know, impacted me about the word scared for our younger generation coming through, that they really feel quite overwhelmed with, and we talked about the culture of anxiety and fear. And being a part of the healthcare system, you know, that really worries me. My question is, how do we broach this? Because it's a whole systemic issue. And is there anything that we can do for our younger doctors and nurses in training to try and combat this? And you also mentioned the rewiring in Denmark, and I'd be really interested to see what happened there and whether there's any learning that we could apply to what we're doing in England.
Thank you. And then the lady at the back.
Stress and then rewiring, okay.
I think there were 2 at the front as well.
Hi, I'm Sheena Asthana. I direct a Centre of Health Technology. I recently departed, I would say fled from ICB land. So you had a really interesting conversation about addressing the power imbalance through creative conversations. For me, I kind of want to test that out. Culture comes from the top, and particularly if you're in a financially constrained ICB that's under NOF4 or previously SOF4 and been in deficit for absolutely ever. Sorry, your ability to, your freedom and autonomy to make decisions outside NHSE regional demands about your urgent and emergency care targets, particularly a deficit, it's all about the hospital. So I'm kind of intrigued about when you're talking about having local conversations, how realistic that actually is.
Yeah.
So there's a couple of things that kind of relate to that. Charlotte, you mentioned that you had come across some interesting conversations. Does context matter here? Is it worse for ICBs that are under financial deficit and therefore under a certain type of control from NHSE? As we're having more and more ICBs under that type of relationship and being told to spend their money on the big four to sort out their deficits, does that mean there's less capacity now for the kind of conversations that you're having? And what needs to change at central level with regard to the relationship between NHSE and DHSC to start to maybe shift what might be the biggest barrier to the types of changes you're talking about?
Thank you very much.
Very controversial.
No, true.
I would say actually exactly the no-go conversation we should be having. So thank you very much. And the gentleman in the middle.
Hi, I'm Matthew Wynne. I lead 2 NHS trusts in the East of England. Just trying to pull a few themes together. Thea, you talked about mechanisms, structure, incentives, and then you talked about the reality of delivering that. And I think just going to our later session on if the new 10-year plan is not going to succeed, well, what would we think would have gone wrong? I had to say from my experience, where we go wrong is that we don't focus on what makes the change. And often that change is about trusting leaders, trusting clinical teams, and I would say the regulatory world then testing out, have we got the right ingredients to make care change? We test out process, we test out mechanisms that we think are the right things. We don't actually sit in front of ever, in my experience, a group of medical directors, chief execs, and say, great, you've done a great PowerPoint presentation, but I know you all don't like each other, and I know you don't trust each other to make that change, and I know you're not leading your geriatric teams with your general practice teams, with your community nursing teams to actually make a difference. So I guess when we get to the point of discussing what's going to make the 10-year plan successful, I think it is also about an honesty of intent and implementation is probably the most important thing, because without those things happening, you can make lovely policy, lots of policy wonks in the group, bow my head to you. You can do all those things, but actually it will not change on the ground. And actually, I'm slightly less in both your camps about, oh, money's not flowing, etc. The only way to make money flow is for people to start taking risk on a clinical, professional, and operational basis together, and change happens, and then the leadership is to make the money flow with that change. So I guess my long-winded way of saying is, how do we then elicit that into what we're doing and the mechanisms of making policy, national and local work, but test the right things?
Yeah.
Great, thank you.
Go through them in order. Colleague, it's very difficult, isn't it, supporting our younger colleagues? But I think that, generally speaking, that happens locally. But one of the big things is making sure, and what we know from the skill mix work and the skills work that Billy led, that's why I'm pointing over there, is the importance of supporting staff and actually having enough money in the system to ensure you've got the right amount of mentoring, you've got the right amount of space to give people time to be supported properly and to listen to people properly. And we often layer in new roles, new jobs, and don't put that in, and we don't put that support in. It's not easy, but it's often at a local level. In terms of Denmark, I'm going to point to another colleague here, Sarah, who knows much more about Denmark and what's going on in Denmark than I do. And so you can talk to her at coffee and she'll say wise and brilliant things to you, which will be great. Colleague at the back, I completely agree with you. The regime that is currently in ICBs, ICSs, for systems that are not financially performing is extremely emotionally illiterate. So it won't work. Well, it will work, but it will work in a transactional way. It will not work in a way that is sustainable, in my view, because it's not emotionally literate. So, yes. In terms of Matthew's points, again, you would know, I would agree with you. I'm not sure if Julian's here yet from CQC. He'll be here late. There he is. Well, Julian will take everything that you've said, clearly, in his new and amazing and revolutionary new leadership of CQC. I think he's laughing. He could be crying, I'm not sure. And he'll be ensuring that way of working with... but yeah, you're right. It's really hard to pull off, isn't it? It's really hard to pull off. I mean, I'd like to be in the room where people go, that was a great presentation, but I know you all hate each other, because it would be quite amusing, as long as you weren't in the room as one of the leaders. But it is true that somehow we have to get regulation to also be regulating the right things and understanding that, and then supporting clinical teams for change. So yes, the relationship with regulation is a really important one.
Great, thank you. I think we probably have time for a couple more questions. If you can keep them as relatively brief questions so that we can make sure there's time for Thea to answer them. The lady at the front, I know you had your hand up before, and then I'll take the lady over this side. Thank you.
Sarah Pickup, I'm Chair of Heart Urgent Care and a Nuffield trustee. You talked about financial incentives, and I just want to follow on some of the things other people have said. Locally, you can have conversations that make things work, but it's more through kind of positive deviance, acting against the system rather than because of it. And the ICBs were only ever going to work if there was follow-through on the intent. So it seems to me it's not just about financial incentives, it's about performance management through whoever does it, whether it's the department, whether it's the region, whether it's NHSE. If they don't measure with equal parity the things that they say they want compared to the things they then seem to want, then they will never change, will they? So if you don't manage whether your partnerships are working, whether you have moved your money into prevention, whether you are investing in primary care, if you don't measure those things, and if community services continues to be like unmeasured largely, we won't get there, will we? So it's about what's valued and what's rewarded, not financially, but what's rewarded in behaviour terms from the top. And the positive deviance will work locally sometimes with relationships are right, but it's not the answer, is it? The answer is that the top mean what they say.
Great. Although I'm totally stealing positive deviance. I love that idea. That's going to be
There's
my
a whole theory
mantra.
about it.
Brilliant. I'm going to go and read about it. Great. That's fantastic.
Yeah, hi, I'm Juliet Bouverie, Chief Executive of the Stroke Association and Chair of the Richmond Group of Charities. So great talk, really stimulating. I always feel nervous when people talk about levers because it implies the NHS is a machine and you press a button and pull a lever and change happens, and we know that just isn't the case. So I suppose I'm wondering about how we facilitate bottom-up change and how we really understand what the right system conditions and enablers for change are that come from frontline teams. So that's the first question. How do you drive the bottom-up change, not just think about top-down levers? And secondly, how do ICBs need to work differently to embrace a more relational model? Because at the moment, their ways of working are incredibly industrialised. They're not relational, so what capabilities do they need to have to build trust and collaborative relationships?
Great, two brilliant questions to end on.
Well, yes. I mean, I'm all for positive deviancy, I think that, and always have been. But you're absolutely right. And I suppose it goes back to what we've talked about, I talked about, has been reflected. Everything has to align. Your performance management system, your regulatory system, your financial flows. It's about the thoughtfulness of the alignment of everything that shows that you mean what you're saying. And that's been the problem for so many years, is the rhetoric and the reality, the policy and the practice just haven't matched up. And so everybody knows that. And you've got to get to a point where everybody goes, oh, they mean it. They really, really mean it. Yeah. And you know, we know that there are ICBs and ICSs, and I can see people in this room who do work on relational models, who are working really hard. I spoke to an ICS lead only last week who's working really hard to create a relational space for their ICS to flourish in and to do that work. And having to be quite tough in that environment, because experiencing similar to what I experienced, which is you're a bit fluffy, aren't you? You should be talking about performance and regulation and hard stuff and transactional and industrialised qualities. Why are you trying to talk to us about the fact that two organisations really hate each other and have set up quite difficult relationships? I think it's hugely complicated to allow us to move from that transactional to more relational way of working, and to celebrate it and to see it as positive, and to understand that that drives high performance. It is not a way of letting people get away with poor performance and poor outcomes. It's a way of ensuring that it is better. But that is quite a big mind shift.
So because you were both so efficient in your questions, we have about 2 minutes left. So I thought I will ask a final question, if that's okay, and then we'll let people to go out. I think maybe to coffee next.
Yes.
Is that right? Yeah. So I also thought, just tying a few of those questions together, we haven't really talked very much about the centre, so NHS England and DHSC, and that feels a little bit of an elephant in the room with some of those questions. So we had the question there about, essentially what gets measured gets done, but more importantly, why we are always having to try and find the kind of different route because the current model doesn't work. We had the question about how do we get ICSs to actually be able to work together in a different way. We had a question at the back which also linked to this, and I think the point for the gentleman around what are the actual ingredients that enable change to happen, how far is being one of the most centralised top-down models of health systems in any comparable country a phenomenal barrier to us achieving some of the more relational, more integrated, more place-based, more outcomes-focused, more patient-centric models that we want to see? Because actually having an NHS England which is so domineering and sets so many metrics which aren't matching the things they say they care about, how far actually do we really need to look at dismantling that central model and, again, devolving more power to those regional entities, whether that's an ICS or we would say actually the ICS model doesn't work, but how far is that?
Totally. As you say, we have one of the most centralised models in Europe, in the world. One of the things that one would hope the 10-year plan will do is be really clear about what should be done once, what is for national setting of a framework, and what is about letting go. So maybe that's something that we'll come back to after the break, as saying that's one of the outcomes we want to see, because it's without doubt one of the challenges that our system currently faces.
I might say in that session afterwards that what will have gone wrong will be if NHS England still exists at the end of it. Is that a fair comment to make at the end of that?
You may say that. Right, we'll leave that as like a sort of tantalising line into the next.
Precisely.
So I think we're going into coffee now.
We are. So, Thea, can I say thank you so much?
Oh, sorry.
That was a fantastic, and genuinely, it's a privilege to be able to sit here and talk to you about what was a fantastic presentation. I'm sure everybody will feel like they've started this 2 days, like really stimulated, really provocative, challenging, but also highlighting those opportunities. So thank you so much. That was a brilliant session. And was there something I need to say as well?
No, I'm going to come up, but let's give Thea
Okay, fine, perfect.